Good morning and welcome to the weekly Dementia Blogs. These are being sponsored by SpectraMed. Again, I am Dr. David Hutchings, and so let's go ahead and get started. Before we jump into the weekly blog, I wanted to mention we got three great lectures coming up. Number one is into August. We have the annual Tennessee Alzheimer's Association Symposium. Where I'll be speaking about dementias and also symptom management. And then we have the Behavioral Health, Middle Tennessee Behavioral Health Conference that I'll be doing a keynote lecture for. And then we have the virtual conference for NARA, where we're talking about, they've actually asked if I would be willing to address how COVID has impacted my dementia patients, but also the caregivers as well. So we're really excited about those upcoming speeches. So I wanted to go back and jump into the diagnosing of dementia because I think that video had like 16 or 17,000 views. And a lot of questions came to me about that video to go a little bit further in depth. And then after we're done with this video, I'm more than happy to go even further in depth in the areas I'll talk about today. So really, when we look at dementia, we think about and define a disease as a condition that either impacts the ability for one to take care of themselves or impacts the ability to take care of others. And dementia, progressive dementias, do both. So really the first thing for us is not to determine whether they have dementia, but to rule out other conditions. So first of all, I'll say that dementia is an acronym. The D will stand for depression or drugs. Depression, as we've talked about before, can cause pseudodementia. And with COVID in play, I have seen multiple patients and caregivers presenting symptoms of pseudodementia. Next is the E is for endocrine. I'm going to talk about that in just a second. Metabolic. The E is epilepsy. The N is for nutrition or neoplasms. The T is for toxicity. You want to rule that out. The I is for infection, which can onset delirium, which is completely different than dementia itself. And then the A is going to be more arteriosclerotic or vascular related. So when we start to rule things out, one of the things we definitely do is look at blood work, look at thyroid levels, look at vitamin B12 levels. It is basically dementias and hypothyroidisms runs side by side. That's why we start to see some of the thyroid start to regulate as we are working with that, but also on the medications to improve cognition. And also looking at hydration and infection as well. So we're looking at a lot of different things here to kind of rule out, okay, if this has nothing to do with the thyroid, has nothing to do with toxicity issues or infection or nutrition. So we start to rule all that out. So next we start to bring in more looking at the biological level of things and saying, okay, let's see if we can get an MRI. Maybe we can get an fMRI if we're lucky, or maybe even a PET scan. And I'll talk more about the PET scan here in just a second when it comes to genetic testing. But also, we're not looking at just memory. We're looking at functional skills. So in a progressive neurological dementia, and as a reminder, we have 85 different kind of conditions that can cause some form of dementia. Yes, but in a progressive neurological dementia, we're looking at, yes, memory. That's one thing. That's only one piece. We're also looking at the functional things as well. So in the cognitive and neurocognitive testing, we're looking at the functional abilities. Are there things that the patient was able to do before? Maybe it's cooking a certain recipe, or maybe it's difficulty managing the medications or handling money, those types of things that we would put in kind of the bucket for more functional abilities, more the activities of daily living or more advanced activities of daily living. And in the testing itself, usually takes a true neurocognitive assessment. It takes at least around 2 hours, and you're looking at concentration, orientation, short-term memory, long-term memory, and of course the functional pieces there. And there's multiple tests that we use to look at all that. And then we also look at interviewing the caregivers as well, and also some of the family, and then looking at what skills have been lost thus far. And so with all that and looking at the memory, we have a loss of personality, difficulty learning new materials, indecisiveness, paranoia, so all these things start to come into play. So really it's not just this one thing that we do to diagnose it. It's more ruling out everything else, because we don't want to go to somebody and tell them that they have a progressive neurological disease without ruling something out. And I love when I get those patients that we think have Alzheimer's, or we think have a vascular dementia, or whatever it may be, and it simply is a thyroid issue or something like that, which is very, very fixable, or maybe depression. One of the questions that we got a lot on this video too was on genetic testing, and I sent a lot of patients their families for genetic testing, especially those who have frontal temporal lobe dementias or those more kind of rare, the not really rare, but the ones that is not as frequently seen as like the very early onset Alzheimer's disease. So there is a genetic test that we can do. We can simply do a test and see if we have the apolipoprotein number 4 or APOE number 4, which is associated with Alzheimer's disease. And we inject a blue dye into the system that's called Pittsburgh compound B. We can then do a PET scan and we can see are there plaques and tangles that are actually in the brain. Some plaques and tangles are normal, but an abundance of those obviously are not normal. And then if we do test positive for the gene, doesn't mean that we're still going to get the condition either, because age is the greatest factor of developing late onset Alzheimer's disease, especially when it relates to as we get to about age 80. So even though that we have the gene doesn't mean it's going to mutate. And if you want more information on this, I had just published an article earlier this year on ways to prevent dementia that have been proven in peer-reviewed literature, even though if we have the gene itself. So as you can see, there's a lot that goes into it. It's ruling out other things, and then it's also a very in-depth testing. It's also very in-depth in terms of in terms of imaging as well. So we're bringing in different things here. Before I close, I would say that sometimes I see patients that go to, it could be whoever their provider is, and there's only a few questions that are asked for the patient, and they can't recall a couple things, and then we can get the diagnosis that way. I would definitely urge against that. I think we really need a more in-depth assessment and ruling out other conditions. The last thing that we do is once we figure out, yes, this is a progressive neurological dementia, the next thing we need to do is figure out what type of dementia that we're dealing with, because that is going to dramatically impact our course of treatment, not only from an environmental standpoint, but also from a pharmacological standpoint. So we'll start to get into more treatment of different forms of dementia in the future blogs here. Again, very excited about this one. If you have more questions, keep them rolling in. And in the meantime, I hope everybody has a wonderful 4th of July weekend, and I hope everybody stays safe. And we'll see you again next week. Thank you.